some of the other places we did go to, we had to go to the grocery store in North Dakota to get our food. It was like 30–40% mask wearing in the grocery store. They living in a totally different world.
I would say the rate among gas station patrons in Nebraska is even lower than that.
Yeah. Did you guys break up the drive then?
We did not coming home. We did. It took us 16 hours to get home.
Oh, that is painful. That's
we got home at 12:30 in the morning.
Ugh. Well,
But
Estes Park is a beautiful place. I mean, we've been there a bunch of times. The hiking up there, especially above Ridgeline, is just gorgeous. Off a Trail Ridge Road up there. I got a lot of good memories of that place.
Great. Miriam, you want to tell us, get us kicked off?
Yeah, sure. I think it's a good time to get started. So first of all, I'd like to introduce everyone here. So thank you, Dr. Purcell, Dr. Clements, Dr. Zielinski, Dr. Ravina, and Dr. Khan for joining us today. So the goal of today is just kind of to learn about your different paths to primary care and answer any questions that any of the attendees have. So if someone wants to get started, just introducing themselves and like talking about how you got to primary care.
Yeah, who wants to go first? You want to go first, Paul?
Oh, go ahead.
Or Deb?
I'll do it. All right, okay. So I'm Deb Clements. I am a family physician and I'm chair of family medicine here at Northwestern. I have been in family medicine for almost 30 years. Time flies. When I was a student, I loved everything. I couldn't imagine not seeing a certain population of patients. I love procedures. I thought about surgery for a little while, but realized most of my time wouldn't be with conscious patients. And so, I couldn't get away from the story, that thread that goes through everything we do. And I think the inquiry that you need to have in primary care, sort of that constant state of learning and not having any idea what the undifferentiated patient is going to come in with, really keeps every single day interesting, regardless of how long you're in practice. So don't believe anybody if they tell you primary care isn't interesting. It's fascinating. And so that's why I chose family medicine. I didn't want to limit my practice in terms of not seeing kids and not seeing pregnant women. So that's how I got here. And I haven't regretted a day of it since. Oh, come on, somebody.
I can go. I'm Kristen Kahn. I'm a primary care pediatrician here in the division of, we just changed our name. We're Advanced General Pediatrics and Primary Care. And I have finished training in 2013 at University of Washington in Seattle and really loved my experience there. I'm a little bit different in the sense that most of my time is actually as an investigator. So I'm a clinician investigator. So I see patients once a week, and then most of my other time is what we call dry lab research. It's a lot of database research. And so that's probably what my typical week is. And I fell in love with primary care pediatrics during residency. So University of Washington, sorry, this is not supposed to be a promo, but like we had a different model. I don't know what other models are like of having an intensive for 2 months in our second year of training where we get sent to a primary care site, not near our home institution for 2 months. And so that included, so if we were in Seattle, it was Coeur d'Alene, Idaho, Boise, Idaho, Bellingham, Washington, which are places that are a minimum about an hour and a half, 15-minute drive, Yakima. And the idea was that, residents get so embedded into their primary health system and health institution that it really gave us an opportunity to see how community pediatrics was practiced across, the country, or at least across our state. And what I really appreciated about that was getting to build that continuity relationship with families. That's something I very much enjoy. And I think especially in pediatrics where, the developmental milestones and understanding the development of children is so crucial to that continuity relationship. I really appreciate that dynamic. And so really loved getting to do that in primary care. And I think since that time have also watched other individuals really take on different roles, even in primary care as community pediatricians, whether it be involvement with the American Academy of Pediatrics doing advocacy. One of our other colleagues, who couldn't be here today, Mariana Glusman, does a lot of work with the Reach Out and Read program, and so supporting early childhood development. So I think there's a lot of great opportunities in primary care pediatrics.
I'm happy to go next. I'm Paul Ravenna. I'm a family doctor at Northwestern. I finished my training 6 years ago, trained at Northwestern, and now I've been here ever since. I practice in a primary care clinic in Lakeview 2 days a week, where we do lots of chronic disease management. Based on where we're located in the city, there's also a large population of LGBTQ+, and so we do a lot of HIV care, PrEP, gender affirming care. So it's a really fun clinic, comprehensive reproductive and sexual health. And then the other 2 days a week, I'm supervising residents in my other role as the associate program director for Dr. Clements' program, family medicine residency program at Lake Forest. So I get to sort of watch them on their journey and help them in their primary care clinics. And then another day is allegedly an administrative day. But I think, like everyone on the call, we sort of fill that administrative time with other fun things, research and meetings and committees. And so it's a nice split. I got to primary care and to family medicine through a set of experiences that I had in medical school. I went to medical school to be an interventional neuroradiologist, and I think now 6 years into like my actual medical career, after 4 years of medical school and 3 years of residency, I'm pretty sure I know what those words mean, but I'm still not 100% sure I know what that job entails. But it was a series of experiences that I had working in a free clinic in medical school that really led me to this sort of epiphany that when people are feeling vulnerable, they think of their primary care doctor, and that's a real honor and a privilege, and it's what brings me to work every day. And then now what I try and teach the residents is that a good primary care physician can handle about 90% of the problems for 90% of the people. So there's always going to be times where we need our subspecialty colleagues, and there's always going to be times where we need to refer, or we're not quite sure, and we've reached sort of the limits of what we can do in the primary care setting, but we're always trying to expand those boundaries and do more and more for our patients. And so that's what really led me to family medicine and primary care.
I'll go next. Mike Zielinski. I did my medical school over here. I graduated in '97. I did my residency training in internal medicine over here. Graduated in 2000. I've been at this clinic now for, 21 years. So when I was in medical school, I wasn't quite sure what I wanted to do. I really enjoyed emergency medicine, and that's what I thought I was going to do. I love the acuity and going back and forth and stabilizing people and not knowing what was going to come in your door. But what I realized after doing enough of that is I always wanted to know what happened afterwards. And I wanted to know what actually, they did to help the person get better and what have you. And as much as I liked ER medicine, I realized that I really wanted to kind of handle the other stuff too, rather than just be triaging and stabilizing and then sending off. And so after doing my internal medicine rotation 3rd year, and then I ended up doing an early sub-internship and managing patients with complex diseases. That is what appealed to me most. And so I decided to go into internal medicine. When I did my residency, there was a little bit of time where I was thinking of subspecializing, but a couple of things came up. Number one, I realized I liked a little bit of everything. I mean, as a primary care doc, you are dealing with one patient with depression, the next patient with arthritis, the next patient with heart disease, the next patient with lung disease, and the next patient with all 5. And I really, that's the stuff I really liked. I didn't want to box myself in. I also, kind of wanted to be someone's doctor with a capital D, and that's what I feel like I've become. I'm full-time, so I don't have any research or anything. I don't have any scheduled teaching time. I end up doing, we volunteer teaching, and so I squeeze that into my schedule. I do the primary care clerkship over here, but it's full blow. All I do is see patients all day, and it's been incredibly rewarding on that aspect. I will say, my clinic is a little different than Paul's. So, and this is the interesting thing about primary care is you can be the same specialty and have completely different worlds. My world is mostly geriatrics. I take care of mostly patients over the age of 65. It's about 60 to 70% of my practice. And part of that is because the practice I joined 20 years ago actually had a cardiologist and an endocrinologist in there. So as soon as I started, they sent me all of their patients to be their primary care doc. So these people that I picked up at age 60, 65, I'm still seeing now at age 80 and 85, and kind of by default, I've become a geriatrician. But really, from my standpoint, the thing that I love and really is that I don't know what's coming in. It keeps me on my toes all the time. As Paul said, I really feel strongly, I like to take care of as much as I can so that patients don't have to go elsewhere, keep the medical costs down. I mean, we really are stage one in terms of that for the country. And, being someone's doctor is very rewarding. There's a few percentage of patients that you wish would fire you and you don't want them to be, you wish they weren't your patients anymore. But the vast majority of my patients, I mean, I come to work every day and they keep me coming back to work every day.
So I'm Steve Purcell. I'm also a general internist, and I have kind of like 4 different jobs. I am about a quarter of the time I spend seeing patients, some of my own, some with residents in the outpatient setting, and I do 2 weeks of the wards per year usually, although this year was a little bit more with the COVID outbreak. And about half of my job, similar to Kristen's, is really extramurally funded research. It's a lot of research related to how do we change the way we deliver care, how do we introduce technology into care, how do we tell how good a job we're doing, delivering care, and how we think about new ways to do it. And I was drawn to a lot of the same things that my colleagues have mentioned. I mean, I really didn't want to give up any disease or organ system. I wanted to be patients' doctors over a long period of time. I would definitely emphasize the role of sophisticated, complicated judgment in primary care. How, who to work up when they mention some symptom in their chest versus not. I mean, it's like a lot of times in subspecialty care, things are pretty much, the management of chronic illnesses that come and go in severity or over a time course. But in primary care, you are always on your toes. Which symptoms need follow-up? Which things should be reassured? Which things should have watchful waiting? How much of a workup to do initially versus waiting? Tons of, really challenging clinical thought and decision-making. And on the research side, I really like the ability to think beyond a simple disease, a single disease. It's like, how do we structure care so that it does a lot of the things that we need it to do, not just take care of one condition? How do we use technology? How do we take care of diverse patients that have problems that are outside of a disease area, but are more related to social factors or economic factors? And then the sort of the last quadrant of my job is actually working with the health system to actually try to do system measurement and improvement to try to say, well, how do we think about making primary care better across 60 different primary care practices in a health system that goes all the way from Wisconsin down through the Chicagoland area and out to DeKalb County, and is getting bigger every day and has very different populations, different practitioners, different cultures. How do you use organizations and technology and communication and other tools to raise the level of care across that? And how do you coordinate things? I mean, one of my favorite jobs as a primary care doctor is really being an advocate for steering people through complicated things that involve different subspecialists, that involve like closing the loop and making sure that the right things are happening and that the right people are weighing in on the right decisions for patients. So even though I might not be an expert in something, I really know I need an electrophysiologist to weigh in on this. And sometimes I can get that done even without an appointment with her patient because of having colleagues and friends. And sometimes I can set my patient up and get them into those clinics, and then sort of help quarterback that. And then the last thing is really, I too have been here for 18 years now, and watching patients grow old, watching them go through different stages in life, watching patients, transition from fully active working to retired, to developing dementia, and like what does that teach you about human nature and the kinds of relationships that you have with patients, and then transition to relationships with their adult children or their caregivers. So it's just incredibly rich, and really never a shortage of things to do. So I know that we have some other questions that we can pose to our group of, but we also are very interested in your questions about careers, about primary care practice, or anything else.
Yeah, does anyone have any questions? I also have a list, so.
I have a question.
We can hear you a bit. I don't think we can hear you anymore. Did you want to?
Like she just muted herself.
Oh.
Oh, here we go.
Yeah, so the question is, how do you deal with paperwork and messages?
I'll start with that. So the paperwork is annoying. I mean, every doctor is going to have annoying paperwork, whether you're a specialist or you're a primary care doc. But the truth is we probably have more of that. You've got patients who are perhaps on an HMO and you have a specialist orders a CAT scan, and then it is up to us to get the CAT scan approved as the HMO primary care doctor. So the thing that's helped out here at Northwestern, at least, is we do have other people that are helping out with paperwork. Like we have actually now a pharmacy nurse that handles most of my refills, and she does all of my pre-authorizations, and that saved a lot of time. When I was doing it on my own, it really got to the point about 2 years ago where you were spending probably a good hour or two a day doing paperwork, and that's just that is not sustainable. I mean, nobody wants to do that. So hopefully, you find a practice that does give you a little bit extra support with that. The messages are difficult too. I feel I've done a bad job with that. I think I've made my patients too comfortable with emailing me about stuff. And, I come to work every Monday morning and generally there's 30 or 40 waiting for me. And I feel that's too much. And I think I'm too nice to my patients about that. So I got to figure out a way to be more evil to my patients. If anyone can figure out how to do that, let me know. But what I generally do with those is, when you look at a message, there's stuff that's easy. Okay, if there's a quick question, you answer it, you move on. If it takes more than a few ounces of brain cells, I absolutely tell them to schedule an appointment. If it's a long message or if it's part 1 of 3, you definitely just have them schedule an appointment, because there's no way you should be spending 15 minutes trying to figure out what to do. And then there's other messages that are following up on stuff you did like a week ago, and those you kind of have to, just take care of. So it is a large part of your day. I mean, a large part of your day is answering messages, and you are dealing with all this other stuff that you have to do. The more help you can get, the better off you'll be.
And so despite the recent weeping that a well-known ophthalmologist had on Twitter lately with regard to family medicine, I don't know if you saw that video or not, it is not that bad. Yes, I agree. There are MyChart messages and calls that you have to respond to. But as Mike said, having a team and having everyone practice to the extent of their license, the highest extent of their license, really helps. And so establishing expectations with your patients about what will be responded to immediately and what we can take our time with, and letting that be known is key to managing the volume. There is always more work to be done. And I think that's true in every specialty. And so it's important to not allow medicine to just eat you up in that way, and set appropriate boundaries.
And I think, though, that there are a lot of it's a very good question when you're looking at potential jobs. It's like, who in the practice does X, who does Y, who does Z? If the answer is always the physician, you might want to look at a different job. I mean, like Mike says, I don't do most of my own refills. I don't do most of my own forms except for signing my name on them. I don't cull the information out of the chart and put them on the FMLA forms. And a lot of work in primary care is about how does a team work together, so that we've increasingly used our team members who are advanced practice nurses or physician assistants to respond to some of our MyChart messages. And again, realizing that it's not the patient's fault that that healthcare system is paid for the way it's paid for, and it may change, but we do actually need to have actual telehealth visits or face-to-face visits, given the way the current reimbursement system is often. So again, like Mike, if it's like, this is pretty complicated, why don't we talk when we have a visit, really give it its due. That's all fair. But it's also very reassuring to be able to give somebody a little snippet of advice that sort of, just makes your patient who you've worked with so long feel better and reassured and like, thank God my PCP is like watching out for me, or nobody else can answer that question so quickly. So there's something really wonderful about being able to respond to some of these messages too, make people's lives easier and better. But definitely figure out who's doing what paperwork in a practice that you're thinking about joining.
I guess I'll just add, similar in pediatric care, our clinic is in Uptown, and so we see about 90% plus Medicaid patients, and we also see a lot of children with medical complexity, so children with G-tubes, trachs, and there's different waiver programs that they can be a part of based on the state. And so like everyone else has said here, our primary care medical home model includes a lot of wonderful nurses and medical assistants who help with a lot of the paperwork that comes associated to making sure our patients get all the resources they need, whether it be referrals to early intervention programs or other types of school-based programs and coordination with that. Our social worker helps with that too. I try to be very transparent that this is our academic primary care model, right? And I think when you're looking at other places asking about how they care for some of the children that have higher needs, because we coordinate with other systems as well, and who helps to facilitate that will be important.
We have another question in the chat, which is, what do you think the future role of the MDDO will be in primary care in the setting of increasing but still unclear role of advanced practice providers in primary care?
So I'm happy to take a stab at this one. I don't fear our jobs being taken over. I don't know about how the other doctors feel. First of all, APPs are in every field, but I don't feel there's that like PAs or nurse practitioners going to take my job. Right now, there's such a shortage of primary care physicians across the country that we are all sort of thrust into the role of primary care provider. But I think what we haven't quite done is figure out an ideal role for each of these, like for APPs and for doctors. Because to be frank, like there's things that we do in primary care that require 4 years of medical school and 3 years of training and years of experience to be able to navigate complex diseases, to understand when is chest pain going right to the hospital, when are you getting an outpatient stress test, and when am I not even writing that down? Like there's some skill involved in this that comes with all of that training. And then there's stuff that doesn't require 7 years of training. You don't need to have done this for 20, 30 years to know how to do a physical. You don't need 20 or 30 years to know how to do an ankle sprain. So I think what we really haven't done as a primary care field is figure out the distinct roles of these groups. Of what is the skill set that a nurse practitioner brings? What is the skill set that a PA brings? And what is the skill set that a doctor has? Because right now it's the doctor and whoever else is there. And so I do envision a more collaborative approach in the future, where we're working more together and we're all on the same team with the same goal of providing optimal care to our patients. We just have different roles on that team.
Yeah, I definitely agree with that too. And I think that it's evolving, but I think that in a perfect world, we work together as teams so that we can actually have more patients. And the best distribution of labor is a lot of complex or undifferentiated things, or are sort of directed toward the physician. And the other thing is that there's team-based care for chronic illness. So if I have diabetes patients who need drug titration or adjustments, or heart failure patients, even if you're a heart failure cardiologist, It's like you cannot physically do every patient encounter for all these things. So if you can be in a practice where there's a good division of labor, there's good teamwork, and it makes sense. I think the hard thing is, can we generally try to steer the complicated hospital follow-ups to the primary care physician, and the sort of less complex chronic illness patients to our APP colleagues. I think that's the best, or to do this tag team where there's, I may see them for 3 different things, and then the blood pressure needs an adjustment in 3 to 4 weeks, and it just can expand your capacity as a practice to see more patients and take care of them, because there's so many people who need primary care who there's not enough primary care physicians to do it.
I'll second everything everybody said. And Alex, I'll be blunt. You will be needed. If you become a primary care doctor, you will absolutely be needed.
It's interesting. This has been a question for decades. And I don't even know that it's the right question. So certainly none of us feel threatened or that we're going to be displaced by APPs. Again, it's the team that matters.
So the next question is, for those conducting research, how you decided to focus on research? Is it difficult to get funding? Do you need fellowship or other training? So Kristen and I can do that one.
Do you want to start, Steve?
You go ahead. I'll go after.
The answers to all of them are yes. No, I'm just kidding. Well, so my focus actually emerged during fellowship. I wasn't interested really in any research. I've never pipetted anything except for organic chemistry or biochem back in undergrad. But I've always been interested in public health. And so, for example, in undergrad, I was already reading health affairs and very interested in health policy. And so it became a budding interest of mine to understand like what my role as a physician would be in understanding health policy structures and how that dictates even a little bit like Alex's question of like, who gets to practice what, how do we deliver optimal care to patients? And so I attended a program called the Robert Johnson Foundation Fellowship Program at Michigan, now called the National Clinician Scholars Program. And part of my interest for applying for that program was because of the focus on health policy. And I thought I was going to graduate from it, practice as a physician, and then also work for like a state-based agency or federal agency, and really fell in love with getting to design my own research questions, understand its implications for at the time, Michigan was expanding Medicaid and really interested in how to better roll out its implementation of Medicaid expansion in Michigan. And so, really focused on what the implications were of the Affordable Care Act on pediatrics, because that was not the focus of the Affordable Care Act. Was really about expanding coverage for adults. So yes, I think that not everyone has fellowship training, but I think most everyone does. I don't know if that's the right phrasing, Steve. And funding is competitive. I think that would be the best way to answer that. And so when I was preparing for the conclusion of my fellowship, was trying to figure out whether I wanted to be A, academia or not, and then B, if academia, did I want to be, there tends to be prescribed tracks in academia of clinician educator, clinician investigator, and they all come with their own trappings. And I think from my perspective, every position anywhere comes with its certain set of rules, whether, some of my colleagues decided to go work for a state government as like Assistant Secretary of Health Innovation at the state of Pennsylvania. And those jobs are also time limited because governors get elected and not elected. And so, right, there's a set of rules to be played anywhere. And I think, so for research is getting your own funding, maintaining that funding for your protected time. And I decided that's really what I was interested in doing, because I was interested in further exploring some of the questions that I had in research, and really enjoyed that. But like I said, I think from my perspective, from a pragmatic standpoint, there, understanding what the trade-offs are about your decision and trying to be as open to that, it can look in different ways and there's upsides and downsides to all of it. And then finding out what best resonates with what you're interested in and your personality type was probably how I've typically approached that discussion with other folks.
And I agree a lot with what Kristen said. I think I got into, there's no other physicians in my family. My mother is a sociology professor. I was a history major and didn't really think I was going to go into medicine, but then sort of had an interesting trajectory where I realized I really like science also, but I didn't want to give up all the complicated sociocultural parts of life. So I think that's part of the reason I went into primary care. But I did do a fellowship program. I was in 4 + 3 + 2 years at Harvard and Brigham and Women's, and got to start doing research as a senior resident with a really great primary care research mentor who's now at Michigan, John Ianian, and continue with him during a T32 program, which was largely paid for, by grant funding. So I got to take do a public health degree at Harvard School of Public Health. That was also largely supported by grant funding, and have 2 years to do mentored research. But again, it's like always love the one-on-one with a patient, but also never really wanted to give up well, how do you do this for a population? How do you solve this problem more generally? So I guess and then funding wise, thank God it hasn't actually been terribly hard. It gets easier to write a paper. It gets easier to write a grant proposal. It gets easier to do another grant proposal so that if your next one gets rejected, you have another one that might get funded or revised and resubmit it. So I've been fortunate that it has not been a struggle for the last, since I did my K award in 2005 onward. I will say that not everybody ends up staying in research, and the consolation prize is that they often tend to, I don't think their income suffers at all, and it may actually go up, but it also, they have a whole host of leadership and other things that they do if they don't stay in research. So I think that while not everybody has a successful, this is true in basic science, this is true in clinical subspecialty, and it's true in primary care, not everybody has a sustained funding success, but often they end up doing phenomenal things with their skill sets. So that's, it makes it less daunting because they can always practice, they can often be leaders, and they can often use their analytical and research skills, to solve other kinds of problems.
Yeah, thank you. And I guess so from a previous list of questions, kind of going along with that, since you all mentioned that there are like different populations that you see, what kinds of research do you specifically do or can you do in primary care?
You can do almost anything in primary care. I mean, in our division alone, we have an international expert on peripheral arterial disease, Mary McDermott, who's also an editor at JAMA. She's a general internist. She does basic science. She does clinical, trials in peripheral arterial disease. She's not a cardiologist. She's not a vascular biologist, but she's a leader in that field. And then you could take everything from that to somebody who's a policy expert who, is trying to influence Medicare or payment policy or health system design. I think there's a lot of room for things like, how do you design clinical, care delivery to take care of either common acute problems, kind of prevention problems, chronic disease problems. How do you think about problems that don't belong to a disease system? Like how do you care for patients who have social vulnerability? These things apply across, many disease processes. How do you deal with complex care? But there's not a narrow limit. I mean, I think that you could really pick some unmatched things, but I can always probably find an example of somebody who's an expert in the primary care treatment of mental health disorders or substance use, or somebody who's really studying how to optimize care teams or use technology or use sensors or use health information technology.
Yeah, Steve's absolutely right. I think of primary care as the specialty of possibilities. We don't limit ourselves based on disease state or patient type. And I think one of our greatest attributes is our ability to problem solve. Again, we see that patient who's weak and dizzy and have to think about that across all contexts. And that same principle applies to the research that we conduct. So it's all possible to you. It really depends on your own interests and where you find that your skill set lies.
Yeah, I mean, I agree. I'm remarkably biased, but I think primary care is the future of medicine. And I think we've been hearing that for a while. I think it's actually starting to happen with the way reimbursement is changing and more actual value being placed on primary care. But I think what's for sure is we don't know what that future is going to look like. And so we need people who are going to try new things. How do we incorporate technology? How do we change this delivery model? How do we do relatively simple things, definitely not simple, like how do we decrease the burden of paperwork in one clinic versus how do we, and then bigger things like how do we expand, how do we improve health equity across the country? Like there's so much huge, there's so much need for all of this stuff because we are in a place right now where we're sort of shaping what that future of primary care is going to look like. But we're scientists and we're nerds, and so we can't just guess. We have to have this done objectively through research.
Yeah, thank you. And then another question. So how has primary care evolved since you all started?
I'll go first on that. So when I started, we were still doing both outpatient and inpatient at Northwestern. So I'd wake up, I'd go see all my patients and do rounds. I'd come back, I'd see patients at the office all day, and then I'd go back and see my patients before I left in the hospital. So it really has become much more, you're either an outpatient doctor or you're an inpatient doctor. So that changed about 16, 17 years ago, and I think that's there to stay. The paperwork burden has definitely increased. As I said, it's been great that, there's been other people that have helped relieve some of the burden with that. It is so much easier to get in touch with your doctor now. It used to be you had to go through the phone system. So you actually had to make an effort to call your doctor. And the call volume has decreased, of course, but the email volume, the portal message volume has really increased. And so it's so easy to get in touch with your doctor. You get people asking, hey, my eggs are 2 weeks old in my fridge. Do you think I can still eat that? And you have to say, that's really not a doctor question. There's other things I need to be dealing with during the day. So you have to be a little bit careful about that. But, and then, of course, over the 20 years, disease processes have changed completely. I mean, HIV 25 years ago when I was a resident and half your hospital census was HIV patients dying, that's completely changed. And so one of the things that is important is you have to keep up with everything that's changing around you. You've got to keep up with the literature. Things are going to change over a 20-year period and a 40-year period. So HIV is just one of the many diseases that have changed completely from when I first started.
Yeah, the other thing that's changed is the pace of change, right? And so things have evolved much more rapidly over time, but we have access to information in a way that we didn't before. So the electronic health record has come into being for all of us. We can read everything now. I remember as a resident, there were charts that were illegible, and so you just didn't even bother. We don't have that problem as it exists now. And so I do think when you choose a training program, it's important to choose one that teaches you how to be a master adaptive learner because things will continue to change and we have no idea in what direction. So you have to be someone who's really interested in lifelong learning, but also develop the skill to be able to do that.
Yeah. I think that, and that realizing that some of the ways we learned how to do things were really not the way we think about them now. And because you're not narrow to one field, you really have to keep a breadth in a whole range of fields. You have to tap new knowledge. You have to be mentally flexible. You have to be able to incorporate new knowledge. And you have to be like a very shrewd consumer of knowledge to know when is it time for me to change my practice and when should I continue to do things the way I've been doing them. So it's never dull.
Yeah, I really love how you guys just described about being a lifelong learner. And I think of a couple of examples. I think I mentioned children with medical complexity. I think, the way we are able now to support children living at home and in communities that maybe before these diseases had a much earlier terminal kind of just more higher mortality. And So that's really changed the way I think that some primary care practices have taken on caring for these children, which is really fascinating, but also constantly evolving. The other piece I think that's interesting that, again, I feel like such a poser saying this because I feel like I'm not that far out from training, but just a little bit. But just besides infectious diseases and how they've changed in the pediatric population is also just, you know, in my research, we've talked about how like maybe just 10, 15 years ago, you know, the pediatric world and practice in the field was very resistant to talking about screening for postpartum depression in our clinic visits, for example. And that has really shifted, right? Like now, at least predominantly, like we routinely screen with Edinburgh of postpartum depression at our infant visits. I think the newer one right now is around mental health. I think that our adult practicing colleagues are more familiar with potentially supporting depression and anxiety in our patients. And even in one of my smaller practice-based research, you know, when I anonymously interviewed a group of physicians and pediatric physicians in the community, there was varying responses about how pediatricians felt like was it their role to take care of mental health in our patients, which I think the pandemic has only highlighted that the need is very high and that practice change needs to happen in the way that maybe pediatricians before were not managing, but we really need to think about supporting management of mental health in our patients. And so, right, even that has happened, I would say. You know, I feel like the pandemic also pushed that to the forefront for a lot of practicing physicians. And so with that said, I think being flexible that the things that you learn might not be, you know, it's not comprehensive of how you might need, what you might need and all the tools you might need to practice even as you take off in your career.
I have a couple of questions related to that. So I'm a third year and I'm interested in probably going into primary care, but I see there's many different training paths to get there. You know, you kind of make that decision based on populations you want to work with. But are there any, like, I guess I have two questions. The first one is, how do you choose like residency programs? Because I know there's like internal medicine, and then there's like primary care tract of internal medicine, and then there's also like family medicine and pediatrics as well. And then how are you supported after residency in that lifelong learning process? Like whether that's in your practice or if you're affiliated with the university, like how does that happen and like continue to happen?
I guess I would say first you have to decide, do you really want to take care of kids, adults, or both? And then in terms of the lifelong, the residency, I think once you sort of zone in on that, like how much, you know, and really feel like, because not doing family medicine means you're giving up something, right? So all of us who did pediatrics or internal medicine, we did give up the pregnancy care, we gave up the age group that we don't take care of. We gave up some of the procedures, although I still lance a boil now and then, or shave off a wart, or take wax out of someone's ear. So really, those kinds of things you have to ask yourself, really, does that make a difference to you? And then I think you're going to look at the individual programs. The primary care, I can't speak as well to the other ones. The primary care internal medicine programs generally have a larger outpatient component to them. So you're taking care of more patients more of the time. And you know, so I would definitely closely look at the breakdown of how the resident spends their time. Is it how much is outpatient, how much is inpatient? Where are the settings? Who are the patient populations they're caring for? And then you know, other qualities of the residency program. And then in terms of the lifelong learning, you know, it's very different. I think the biggest changes are you affiliated with sort of a hub of academic learning? But even lots of big systems, you know, they spend a lot of work trying to keep their workforce up to par. And how do they support them? So it's very different if you're working in a sort of an academic on campus, you know, always training, always going to lectures, everything else, or a system that sort of has some investment in that, or you're completely in your own practice and like everything you do from CME selection and everything else is your own. That's becoming a smaller amount of practice is conducted in those kinds of environments, but it's still a big chunk of primary care.
I'll add to what Steve said. One of the differentiating factors in family medicine is that we put a primary focus on continuity. And so your patient panel that you care for during your residency think of you as their physician, and you will care for multiple generations in the same family for all 3 years. And so regardless of whether you're inpatient or outpatient, that is your focus, is the family unit. In terms of lifelong learning, hopefully you get a lot of those tools while you're in training, but we all belong to associations that help us with that. And our boards require what's called maintenance of certification. And so while it used to be sat for a proctored exam every 7 to 10 years, depending on the specialty, now we have to do activities every single year to maintain our certification. And so some of that's taken care of for you. But belonging to associations that support those learning needs can be really instrumental in your career.
But all 3 disciplines have extremely nice people, so you can't use that.
Yeah, that's true, but I will tell you, you certainly, you want to go, you're going to interview at these places, you will get a feel. There are different fields at different academic centers and different places. You'll figure out what works best for you. I mean, I won't mention names, but there was 1 or 2 places in the Midwest I went with really great academic credentials, and you went there and you did not feel comfortable. It was a different type of feeling. Certainly nowadays, you're hoping that it's very all-inclusive and very diverse. You want to look for that as well. And although this isn't a deal breaker for me, at least, I was born and bred in Chicago and pretty sure I wanted to stay in the Midwest, so I kind of limited to that. But I think having a little bit of a sense of where you kind of want to live makes a difference. I think it's easier getting a job if you do a residency in the city where you're going to end up working in. That's not 100%, but it's at least something to consider when you're looking at residency programs.
And try to talk to residents and graduated residents to triangulate on your information. We're gonna pitch you about how great our programs are, but I think it's important because you only know you best, right? About what's important to you, what are the idiosyncrasies that you care about, right? And talking to other residents will also help you kind of figure out what's actually important and what isn't. That's the other thing I think that's helpful.
I would beware some of the name and shame websites, those kinds of things. Those are really disgruntled people out there that probably don't represent programs well. So I'd take all of that with a grain of salt.
Did anyone have any other questions?
I guess to follow up on that, is there any like systemic difference in like academic versus community practice, like which specialty would be more one or the other, or is it really just kind of mixed across the board? Because I think as a Northwestern student, we're like pretty biased towards like academic affiliated programs, but yeah, I guess I don't have as much exposure to like people working in the community and to what the spread of job like settings is.
That's a tough question to answer in a really short period of time. A lot of it depends on where you want to practice and what you feel most comfortable with, as Michael said earlier. There's an old study that's been replicated a couple of times called the Kerr-White study. And it looks at if you take 1,000 people in a year, where do those people seek care, right? 1,000 people with symptoms. And only, in fact, less than 1% come to an academic health center. And so what you're learning in medical school and what you're seeing in medical school isn't representative of the world writ large. So I would caution you that this is not the real world. And so, think about that when you're choosing where to train and where to develop your skills. You get one shot at residency, and hopefully just one. And so really choose where you're comfortable and where you think you're going to get what you need to be the physician you want to be.
And in terms of working in the community, it's like there are plenty of all 3 specialties. And I mean, it's interesting because we have such a large system, but a lot of it is really not, the students are not exposed to because of travel time and other, other issues, and just lack, and because it hasn't been set up that way. But yeah, I think that it really, I would try to think about what you think is going to give you the most satisfaction. I'd say traditionally there's probably, but this is not completely 100% true, but there's probably a bit more research in academic centers with general internal medicine and pediatrics, but that's by no means exclusive, because there's certainly researchers in all three of our divisions, our departments. And also I see leaders in all three fields too. So it's like, it's like our associate chief medical officer is a pediatrician for primary care. I work with family medicine docs who run the informatics in outpatient care for our health system, or who led the value-based purchasing until he went off to do some other job, and certainly internists too. So I think I've seen definitely people doing leadership roles on the health system side from all three specialties as well.
I have a question, and I want to preface this by saying, I am very interested in primary care, and especially with the first question, I'm just like kind of airing some of my reservations about stuff that I've heard. And so like one of the things that I've heard from like other people in the medical field about primary care is that oftentimes, primary care practitioners, they don't see that much medically complicated stuff. And so then they end up losing those skills that they've developed in residency. And I was wondering if you could talk to that. What's your experience with dealing with that narrative?
Somebody lied to you, bro. I don't know what else to say. I think people are sick all across the country. Fun fact about our country: we spend the most, we do the worst. American healthcare system is not great. It's not easy for people to navigate. There is no shortage of complexity, whether you're in an academic center, whether you're in a community center, whether you're rural. People are sick and getting sicker. And so we are, what adds to that complexity is they can't always access the things that they need to do. And, like I had said earlier, we're the one that they come to when they have a problem. Like, we're the name that they're thinking of. So they're not waking up in the morning and having a headache and thinking, I need to go see an interventional neuroradiologist. They're thinking, I need to send a MyChart message to Dr. Zielinski. So like, we are sort of the gatekeepers for all of this, and we have healthy people. But like Dr. Khan was saying, pediatrics is not just prescribing amoxicillin. Pediatrics is G-tubes. Pediatrics is trachs and complex kids with genetic conditions that won't make it out of childhood. Like that, it is drinking from a fire hose of all things medicine.
Yeah, and it's definitely great, and it's like complicated stuff. Like I have to hear secondhand from somebody in a skilled nursing facility to my nurse to me about some decline in my patient. I was like, that's way too acute. Bring him into the hospital. And he had a big subdural and he had surgery that night. And it was like, because I heard enough of the story to be able to say, this person has to leave where he is and be transported by emergency. And I had, like 2 months ago, I had somebody who came in for his Medicare physical. He was like, I felt sweaty when I got off the ER. Off the elevator. And I was like, oh, you have an SVT at 170 and you're ischemic. So let's put you in a wheelchair and take you right to the emergency room because you are sick. And also, I never chose to get rid of the inpatient side. And a lot of people do, and it makes a lot of sense to specialize in one area or the other. But fortunately, I've been able to make that work in my practice and get to teach residents and, sort of walk into a room and say, please move more quickly on this patient because their blood pressure is low and they need to be on more IV antibiotics and you need to be calling the intensive care unit. So it depends on where you work, but everybody, if you're a community doc, on an Indian Health Service clinic, you have to know sick from not sick. And you have to say, this person doesn't have to be transferred. This person can go by car. This person is going to get airlifted. This person is going to go home and call me in the morning. Right. So I think it depends on how you want your job to be, how you choose to practice. And I think you can let a lot of skills atrophy, but you don't have to.
We talk about that as the paradox of primary care. How can you possibly know so much about so many things and you're way too smart to go into primary care, right? Those things cannot be true at the same time. And so my advice to you would be careful about by whom you get advice, because maybe they don't really know, right? It's sort of urban myth, rumor, and innuendo. Talk to the source.
And I also think you see a lot of decision making that doesn't display sort of holistic judgment from a lot of different people, including from primary care doctors, but definitely from subspecialists too, where it's like, if you really treated every person who touched the medical system the way you're treating this patient, no one would do anything besides seek healthcare, obtain healthcare. And so it's like, where's the judgment? And it's often takes more sort of high level clinical judgment to say, I'm not going to scan this person's head and I'm not going to send them to the emergency room, than to be an emergency room doctor and to say, well, of course they're getting a battery of labs and a scan and an x-ray, right? Because that's what we do. And in primary care, you actually have to focus the resources where they're needed and know that in a lot of cases they're not. And that's really hard.
Yeah, thank you all for the answers. And I just wanted to say one of the older med students echoed what you were saying in a direct message to me.
Are there any other last minute questions? If not, I really want to thank you all for your time today and speaking with us. This was really insightful, and yeah, thank you so much.
Thank you. Bye-bye. Have a good afternoon.
Bye.
Thank you.
You too.